Well, when and how to give fluids in ARDS, and I disclose the following conflicts of interest with Belgian Medical Systems and Baxter. Let's take that as a very practical question. Let's imagine a patient with community-acquired pneumonia on first day, and the patient has a low PF ratio and PEEP is high. And the patient has already received fluid and is under norepinephrine, and blood pressure is low. And the question we ask ourselves is, should we give fluid to this patient or not? And I think it is really a daily question. And it is a difficult question because we know that fluids are not constantly efficient. And we also know that they may exert harmful effects. In this regard, fluids are just drugs. Many adverse effects. The adverse effects of fluid overload and fluid administration have been well demonstrated today, and the most important one in ARDS is to increase the volume of lung edema. And we know that the more we give fluids to our ARDS patients, the more they die. Fluid overload is an independent marker of mortality in ARDS patients, as we have shown in this study years ago. So we should avoid fluid overload. How do we give fluid in these patients? In fact, there is the resuscitation phase where we start with fluid administration. Then the patient stabilizes, and when we de-escalate resuscitation, usually we give less fluids, of course, but we may also remove some fluids. So how could we reduce that fluid balance? The first means is to give no fluid if we know that fluids will be ineffective. We should detect preload responsiveness. The question first is to know whether cardiac output is too low, skin mottling, urine output is low, lactate is elevated, etc. And then we ask ourselves the question, should we give fluid? And if there is no obvious fluid loss, if it's not the very early phase of sepsis where we should give fluid without predicting anything, in the large majority of cases, then we do not know whether we should or not give fluids. And bear in mind that half of the patients only respond significantly to fluid administration. Today we have several means, several tests and indices to assess preload responsiveness. Let's review these indices and tests during a few minutes. In fact, it's just like when you give antibiotics, you use an antibiogram to test the efficacy of the antibiotics. It's exactly the same with the fluids, which are actually some drugs. The fluid challenge is very easy to perform. You just have to give fluid to the patient and assess the response. There are two drawbacks. The first is that you should keep in mind that to correctly assess the response of a fluid challenge, you need to measure cardiac output directly. The measurement of blood pressure provides you only a rough estimation of the response of cardiac output. But more importantly, the fluid you have administered to the patient, you cannot remove it from the patient if it is inefficient. I mean that the fluid challenge is not a challenge, it's the treatment itself. It induces fluid overload. That's why this idea of a mini fluid challenge is interesting. Give only 100 or 150 milliliters of fluid and assess the response. And today we have some studies telling us that it actually predicts the response of the following volumes of fluid. One point regarding the mini fluid challenge. Keep in mind that it requires a very precise measurement of cardiac output. Here is the study of our French colleagues that demonstrated the reliability of this mini fluid challenge for the first time. And you see that this 100 milliliter starch administration of fluid actually discriminated responders from non-responders to fluid administration. But small changes in cardiac preload can only induce small changes in cardiac output, which were detected in this study with echocardiography. Is echo precise enough for assessing so small changes in cardiac output? I'm not sure. I'm even sure it's not the case. In this study, we have published with Jean-Louis Teboul and Mathieu Josviac last year, we showed that the smallest change in velocity time integral you may trust with echo is 10%. So for this mini fluid challenge, I would rather prefer some more precise techniques, as for instance pulse contour analysis or some other ones, but you need something precise. PPV, pulse pressure, and stroke volume variation are very well established indices. The first one that have been developed to predict fluid responsiveness without giving fluid. But we are very limited in a lot of situations. Everybody knows that today, and likely ARDS is the most important one. Low lung compliance and low tidal volume preclude using PPV and SVV to assess preload response. Nevertheless, I think that first, they have the same limitations as PPV and SVV, except cardiac arrhythmias. But keep in mind that these are likely the less reliable indices to assess preload responsiveness. We have some small studies, and this large French study in more than 500 patients look at the area under the RAC curve with the inferior or superior vena cava variability, which is really not very high. The end expiratory occlusion test, the XPO test, is interesting because it's very easy to perform. In fact, it's all about heart-lung interactions. During mechanical ventilation, each insufflation tends to decrease cardiac preload. And so if you stop mechanical ventilation at end expiration, then cardiac preload reaches a maximum, and the venous return may increase. And if in turn both ventricles are preload dependent, cardiac output will increase, and the threshold is a 5% increase in cardiac output or stroke volume, so a small change. And since the first study we have published regarding this test, some other ones have been published, and we have merged them in this meta-analysis last year. And you see that eventually the test is reliable in spite of some more negative or less positive studies. Look at the area under the RAC curve compared to SVC and IVC changes. It cannot be used in fully awake patients because they tend to interrupt the end expiratory occlusion, which might be 15 seconds long, and it requires a measurement of cardiac output, which is a direct measurement. It's a drawback. Passive leg raising is well demonstrated. You know that it's today recommended by the Surviving Sepsis campaign, along with the fluid challenge, but we have seen the drawbacks of the fluid challenge. Be careful, it still requires a measurement of cardiac output. It's not reliable if you use only the arterial pressure. During fluid administration, there might be some ways to increase the fluid efficacy. I mean that this might be the case with norepinephrine. In fact, when we give fluid to our patient, we increase the volume, the stressed blood volume, and the mean systemic filling pressure, which is in this venous volume. And so the idea is that when we give norepinephrine to a patient, it fixes, of course, the arterial receptors, but also the venous sympathetic receptors. And this induces vasoconstriction of the veins, which may increase this volume, this stressed blood volume. This may increase the mean systemic filling pressure just as does fluid. At least this is the case in theory, but we have demonstrated in 2012 that it is the case also in patients. When we increase the dose of norepinephrine in this study, so we increased norepinephrine, we observed that the level of the mean systemic filling pressure increased significantly, to a lesser extent than with fluid, but it increased significantly. And it's interesting because it means that rather than giving more and more fluids, we may perhaps increase the level of norepinephrine and start norepinephrine early. Also, once we have increased norepinephrine, the next fluid administration might be even more efficient because the volume does not dilute in a very large volume. It reduces the volume of distribution of fluid. And in this study, be careful, it is not published, we mimicked the fluid administration with a passive leg raising at 2 different doses of norepinephrine. And we wanted to know whether at a higher dose of norepinephrine, the effect of passive leg raising on mean systemic feeding pressure would be higher. And it was actually the case at the highest level of norepinephrine. Passive leg raising, mimicking fluid administration, increased the mean systemic feeding pressure more than at a lower dose of norepinephrine. Again, I think it is an argument for giving norepinephrine earlier in our patients. Once we have increased norepinephrine, the next fluid administration might be more efficient. So it might be something helping us. There must be a stop signal. No fluid if the risk is too high. And then the question is, in practice, which indices should we use to assess the risk of fluid administration? Which is this too much signal? Many colleagues use the PF ratio. Basically, if the PF ratio is very low, then I stop fluid or I refrain from fluid administration. It's readily available. Nevertheless, the PF ratio is not directly associated with lung edema. I mean that the PF ratio is also related to some other lung injuries, like, for instance, atelectasis. In a patient with a low PF ratio, I don't know really the volume of lung edema, and so it might be not precise enough for assessing that risk of fluid administration. PAOP with a PA catheter or CVP, which is an indirect estimation, might be interesting because they give you the hydrostatic pressure inside the vessels. But again, it's an indirect assessment of the risk of fluid, because if you go back to the very basic physiology, the relationship between lung edema and the pulmonary capillary pressure, you agree that when you give fluid above a given threshold, lung water, lung edema increases. But the problem is that it all depends on lung permeability, and the same fluid infusion might be much more harmful in a patient with a capillary leak, an important a large capillary leak. And so it tells you that the given value of CVP does not precisely tell you the risk of fluid administration. And perhaps it's an argument for measuring lung water directly. And you know that it is possible with these transpulmonary thermodilution devices, where you inject a cold bolus in the patient. It estimates several intrathoracic blood volumes, including the extravascular lung water. And I don't show these studies, but we have arguments today to tell us that it is a reliable estimation of lung water. And of course, it is better than the PF ratio to assess the risk of fluid administration, because it is elevated only in case of lung edema. It is associated with prognosis, which means that these are meaningful indices. Otherwise, it wouldn't be possible to show that it is related to prognosis. And this is what we confirmed in this meta-analysis, which is not published at the moment. We merged all the studies showing the effect of the volume of lung water on prognosis of different kind of patients. It's lung water, but also lung permeability, because these devices estimate the degree of the capillary leak. They measure lung water, but also the pulmonary blood volume. And the ratio between both indicates the ratio of what's out of the lungs over the fluid what's in the lungs. And so it has something to do with lung permeability. And so how could we use these indices to guide fluid administration? I mean that in a patient with lung water which is slightly elevated, above 10, and permeability is slightly elevated, we may safely consider fluid administration. But if lung water is very elevated and permeability index is very elevated, then we may rather use something else, and perhaps norepinephrine, to restore hemodynamics. Once we have given fluid, at the de-escalation phase, the question of fluid removal is important because it's a very good way to reduce the total cumulative fluid balance. But here, and there is a very practical question. How much fluid should we reduce, should we remove with, for instance, ultrafiltration or diuretics? I think that for answering this very practical question, again, assessing fluid responsiveness might be interesting. This is what we suggested in this study. Before ultrafiltrating some sepsis patients, septic patients at the de-escalation phase, we had performed a passive leg raising test. And the hypothesis was that patients who were preload responsive were going to not tolerate fluid removal because they are sensitive to preload changes, and cardiac output will decrease if you remove fluid in these patients. And actually, it was the case. Patients with a positive passive leg raising with preload responsiveness did not tolerate fluid removal, and they had intradialytic hypertension. And so likely it is a way to guide fluid removal. If my patient has preload responsiveness, I should not remove fluid, and otherwise I know that I may remove fluid safely. Perhaps another way to guide fluid therapy in ARDS patients. Thank you very much for your attention.